Hi everyone, this is your recording of Lecture 3 for Practice Management. You can go ahead and follow along with the slides posted on Blackboard. This week we're going to be talking about managing operations, part 2. So we're going to be discussing ensuring quality in pharmacy operations, risk management, preventing medication errors, and compliance with regulations and regulatory bodies. So I displayed the learning objectives in Chapter 8 on slide 3 for you guys. This may seem a ways off to ensure quality in your pharmacy. If you work for an employer, they will probably have measures put in place to adhere to quality. If you work for an independent, maybe you have a little bit more of input into quality, but considering your license and the health of your patients is at risk with quality, we want to make sure that we understand how it's determined. So let's talk about what is quality in pharmacy practice. So the U.S. Office of Technology Assessment, or OTA, defined the quality of medical care as evaluation of the performance of medical providers according to the degree to which the process of care increases the probability of outcomes desired by patients and reduces the probability of undesired outcomes given the state of medical knowledge. And then the Institute of Medicine, or IOM, in a report entitled Medicare Strategy for Quality Assurance, stated that quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with professional knowledge. And we look to Medicare to set a lot of standards because they're a federal entity. So how is quality measured? So by 3 ways traditionally: structure, process, and outcomes. So this relies on the premise that a quality outcome is not possible without appropriate structure or process. So moreover, it is much simpler and less controversial to measure structure and process than it is to measure outcomes. So measuring outcomes, though, recently has become more prevalent. Like we've talked before, we used to have a fee-for-service model. Now we have a fee for outcomes. You get reimbursed more by insurance providers if you have good and positive outcomes. So in the realm of pharmacy, raw materials or structure necessary for quality care can be varied. So for example, the number of pharmacists per shift, counter space, pharmacist credentials or licensing, pharmacy square footage, medication reference books or online resources, medication stock, and counseling facilities. And because pharmacists are responsible for all phases of medication use, processes in the pharmacy can refer to any phase of the medication use, right? So we can apply quality to prescribing, transcribing, dispensing, administering, or monitoring. So examples of process measures include adherence to clinical guidelines or pathways, percent of prescriptions assessed for appropriateness, and percent of patients counseled. So we've got 3 methods for ensuring quality in the practice of pharmacy. So number 1 is quality control, and this can be thought of defect detection. So problems are addressed after they occur. Maybe there's a glitch in the computer system that doesn't carry over the correct generic that was chosen for a brand medication, right? So then we realize that later as we're running quality assurance metrics and we see that there's a glitch in the computer. So then we have that's quality control. And then quality assurance, we want that to prevent defects. Then once we use quality control along with quality assurance, that's where we get to continuous quality improvement. And that's going to be also called total quality management or total quality control. So you probably will hear of CQI within your organization and your employer. So CQI really incorporates QA and QC, and it represents total systems perspective concerning quality. All workers within the healthcare system are interconnected. We want to make sure that everybody working together is having a positive feedback on everybody else. The computer system is working appropriately. Inventory management is accurate. People are well trained to use the computer system. And then CQI really demands that the quality assurance process is continuous and never ending, right? So in healthcare, we are striving to always learn more and improve upon our processes. So let's take a look at slide 7 and the CQI measurement cycle. So we've got our background, methods, results, conclusions, and recommendations. So let's look at the background. This is going to start with our focus description. So usually your employer or healthcare organization will decide what is going to be the focus for quality improvement. They want to make sure that each team is invested in that decision. The focus importance is going to be the selected focus should be important to everyone and have the potential to lead to improvement. We don't want to put in an upgrade in a computer system if it's not helpful to everybody. Then we're going to do a literature review. We want to relate the focus to the literature by investigating what is known and what is not known. And then our goals. Once the focus is chosen, the team should determine the overall goal. Then let's look at methods on slide 9. The interventions are going to be discovered through a literature review and should be included on a list of possible interventions. The process and outcomes measured. The team member should list process or outcome measures necessary to determine if the goals were met. Next will be data collection procedures. The team can choose from several different data collection methods, including inspection points, focus groups, monitoring for markers, and observation. And then as we're determining our methods to implement a CQI, last, we want to do a data analysis plan. So the plan statistical analysis should be thought out in detail to make sure that all the necessary information will be gathered. And next on our platform for implementing CQI is our cycle measurement. So this really just includes our analysis of data, right? So we use statistics like mean, median, or percentages, and that is going to determine what improvement we've measured. And then last, what are our conclusions and recommendations? So basically we want to, once we determine what our CQI is going to be, we want to explain the conclusions and the details, the actions that need to take place. So that was just a quick review of probably what your employer is going to do if they're going to evaluate where they can make improvements in their company, and probably what information they're going to disseminate to you in regards to information that you should know. So let's talk about some of the accreditation and compliance companies and entities that you will be responsible for being compliant with. So quite often, quality improvement activities are necessary for accreditation. Earning accreditation indicates that an organization has met predefined standards. The accreditation process provides a framework to help organizations focus on providing safe, high-quality service, and requires that the organization demonstrate to outside reviewers its commitment to continuous improvement. Again, this is really a big push in arenas such as affordable care organizations. So first is the Joint Commission. The Joint Commission was established to continuously improve health care for the public in collaboration with other stakeholders by evaluating healthcare organizations and inspiring them to excel in providing safe and effective care of the highest quality and value. So for example, my mom is actually in healthcare administration. She is a quality improvement manager for a day surgery center. And every year or 2 or 3, depending on how long they are approved, the Joint Commission comes in and audits all of their processes and workflow. And it's not necessary, but then the surgery center is recognized as being Joint Commission accredited. And that's going to be good for your patients and for doctors that want to process or practice there. So if they see you're not Joint Commission accredited, that's actually could be a warning sign. So then the National Committee for Quality Assurance was established in 1979, but since 1990, the NCQA has operated as an independent nonprofit organization that reviews and accredits a broad range of healthcare programs, such as health plans, patient-centered medical homes, PCMHs, preferred provider organizations, and sometimes even independent physicians. Quality measurement, sometimes called report cards, they make healthcare quality indicators readily available to the public. Again, if you're a savvy consumer, you may look up if you're having day surgery and you have an option to go to a lot of places. You may look online and see who has the best report card to get your tonsillectomy. Then we've got the HEDIS tool. So this is a big buzzword that's going on in the marketplace, the Health Plan Employer Data and Information Set. So it's a tool created by NCQA to measure performance, and it's actually used by more than 90% of America's health plans to measure performance. So guys that are going or considering managed care, HEDIS is something that a lot of health plans like Blue Cross Blue Shield, Aetna, Humana, they're going to use this tool to measure their performance. The Leapfrog Group was developed to create a market that rewards quality, not just the lowest cost provider, by providing quality, safety, and efficiency information to consumers. And the last, PQA, or the Pharmacy Quality Alliance. This is a newer group established in 2006, is a nonprofit multi-stakeholder organization that focuses on developing and implementing quality performance measures, including pharmacy-specific quality indicators. So that's actually been a leading group the last decade, where they're really talking about CQI and pharmacy specifically. So in conclusion, on quality on slide 13, quality is an essential component of competent professional pharmacy practice. In this regard, we're not really talking about our own CQI, that'll be for another day, but this is going to be in your practice site. Increasing quality may have many beneficial effects on any practice, such as minimizing rework and increasing productivity. And a lot of QI changes are simple and can be implemented quickly. I know for my employer, CVS Health, they have a review every year that is constantly asking for feedback from employees on how they can improve processes. And that's a big place where they can garnish information on how to make improvements. All right, and moving on to chapter 9, we're going to talk about risk management, which sounds a little bit intimidating, but important to know because there is inherent risk in practice of healthcare. So I've got the learning objectives displayed on slide 14. We're going to go over quite a few issues of risk today. So this will be a little technical, so try to stick with me here. So let's talk about risk on slide 15. Historically, the primary risk exposure for pharmacists was related to physical materials being lost, right? Fire, flood, theft, or negligence related to prescription filling errors. So again, pharmacists made an error in reading a prescription or QAing a prescription, and there was harm to the patient. Now, currently, the last few decades, our pharmacy practice really has to consider new risks related to technology, electronic data transmission, patient counseling and drug utilization, and protected PHI. So, right, we talked about last week, there's a mandatory counseling law in effect now, and that's related to risk. We talk about if you are counseling a patient, that is hopefully going to decrease your risk. So let's look at the definition of risk on slide 16. So risks are associated with negative outcomes. A risk is anything that threatens the ability of a person or organization to accomplish its mission. So a speculative risk involves a chance of gain or benefit as well as a chance of loss. Speculative risks are not insurable. So for example, gambling is the prototypical speculative risk. And then pure risk involves a risk in which there's only the opportunity of sustaining a loss. There is no opportunity for gain. Pure risks are considered accidental, unanticipated, or unavoidable. Illness, death, fire, flood, and most accidents involve pure risk. And insurance is a product designed to assist people in managing their exposure of these unanticipated or accidental risks. So individuals or businesses can purchase insurance for risks involving health, death, and damage to home and business property. So I personally have independent pharmacist coverage insurance, so that if I were to be involved in a lawsuit that is in relation to my practice of pharmacy, I have additional coverage outside of my employer. So let's talk about risk management strategy and process on slide 17. There are 5 steps that organizations should follow when developing a risk management process. First, we want to establish the context. So what are the goals of the risk management process? What are the potential vulnerabilities of the business? Do employees or patients risk injuries or both? What reputation would the pharmacy suffer if a patient was injured owing to a prescription error? And could costly claims be avoided by not providing certain goods and services. Next, we want to identify and analyze risks. Pharmacy managers should start by analyzing each dimension of their operation. Some examples of risks faced by pharmacies include activities inherent in their business, right? Filling prescriptions, counseling patients, providing professional services. We want to make sure we provide those according to the practice of pharmacy. But other risks faced by pharmacies include making deliveries. What if someone got in an accident while they were making a delivery? Maintaining the building, sidewalks, and parking lot. What if someone tripped or fell? Preparing sterile products. What if you contaminate or your hood is not up to code? Maintaining a computer system. So for example, what if you have a power outage? Do you have a backup generator so that you don't risk trying to fill prescriptions without technology? And protecting patient health information. Next, you want to evaluate and prioritize risks. So pharmacy managers really have to prioritize their risks because not every risk can be addressed at one time. Some risks are fairly common yet are not associated with a high degree of loss. For example, prescription insurance claim rejections or shoplifting. Other risks are much less common yet are associated with substantial losses, such as damage from a fire, flood, or storm. Right, nobody was in the building, but that can be a huge loss, or patient associated with a dispensing error. You may inadvertently put in the wrong blood pressure strength, but there is no consequences to the patient. So pharmacies should prioritize managing risks that have the greatest potential to result in substantial losses for their business. Next, we want to select an appropriate risk management strategy and implement the technique. Pharmacy managers must determine which risks could and should be avoided. Policies and procedures should be developed for appropriate risk prevention measures. Additional assurance policies or add-on riders should be secured as necessary. And riders are supplemental policies that provide additional coverage for something that is not covered in the original policy at some additional charge. So for example, these strategies and the evaluation of rich risks to avoid versus those that should be managed should be discussed with consultants or advisors. And maybe you have to buy additional insurance coverage if you deem other risks are potentially could affect your practice. And then last, we want to monitor decisions and update the risk management program. So pharmacy managers should monitor and update their risk management strategies to meet new challenges, threats, and opportunities. So for example, when a pharmacy decides to offer immunizations to their patients, it not only creates new patient care and business opportunities, which is great, but it also exposes itself to additional risks, right? Patients could experience an anaphylactic reaction, patients could receive inappropriate or incorrect immunization, or pharmacy employees could be exposed to pathogens like in a needle stick. Once these new risks are identified, managers must create new strategies for their management. So let's talk about some techniques to manage risks. So first is risk avoidance, the most straightforward. So most pharmacies can't and don't want dispensing prescriptions that involve risk, but every single prescription we fill is at risk for being done incorrectly. So there may be situations where offering a specific good or service is unreasonable, and so you should not do it. For example, most pharmacies choose simply not to perform sterile compounding services rather than incur the expense and risk associated with the preparation of these products. Next is risk prevention and modification. So all pharmacies should take steps to avoid medication dispensing errors, of course. This commonly involves the development of policies and procedures to prevent errors and improve patient safety. So for example, you will be trained on how to use your computer system appropriately and make sure that you understand all the steps to correctly enter a prescription and dispense it accurately to a patient. Next is risk absorption or retention. So pharmacies commonly accept losses owing to shrinkage, and shrinkage is a hilarious term for shoplifting, employee theft, unsaleable products, right? So someone returns a medication that they've taken to their home, or maybe they've left in the car, or for some reason they put it in the refrigerator, and we can't allow them, we cannot dispense that medication again, so we have to lose the money that we spent on it. And usually that results in losing profits and then passing higher prices onto consumers. So for example, a deductible on an insurance policy is an absorption of risk. You all have health insurance now because of Obamacare, ensuring that everyone has to have health insurance. And the idea behind that was that if everyone paid into a system, that actually reduced the risk. And some people may choose to pay higher deductibles when losses occur in exchange for lower insurance premiums. That's called a high deductible health plan. So risk sharing or transfer is next. So another technique to manage risk is to share or transfer the risk to another party. Insurance companies commonly share or transfer the risks inherent in paying for healthcare for their beneficiaries by entering capitated agreements with providers, paying them a set amount per member per month, regardless of how much or how little their beneficiaries need health insurance. So for example, CVS Health only offers high deductible health plans. That means everybody has to pay a deductible of anywhere from $1,500 to $3,000. If you have a $1,500 deductible, you pay less on your premium. You pay more on your premium. So basically you're saying, I'm willing to accept $3,000 of my health care, and then my employer will be covered for the rest of it. So it's less risk for the employer. So let's talk about some common insurance terms on slide 19. And these are just good for application in this class, but also in life, guys. You're going to hear a lot of these terms when you buy a house or when you buy a car. Maybe you open up your own practice. So let's start with coverage. That's the scope or extent of protection provided under an insurance contract. Coinsurance is the provision that requires the insured party to share some of the costs of covered services or losses on a fixed percentage basis. This may require, for example, an insured person to pay 20% of the replacement costs. A deductible is an amount of an insured loss to be paid or absorbed by the policy owner. So for example, I just mentioned the deductible for my health insurance, but for automobiles, say for collision insurance, $500 deductibles are common. So you are responsible for the $500 before the insurer is going to give you any sort of money. And then disability insurance. This is a type of health insurance that provides monthly income to the policyholder if he or she becomes unable to work. Next, let's talk about insured. That's the party covered by the insurance contract or persons entitled to benefits under the terms of the policy. So family members under the cardholder would be called dependents. Liability, that's the individual responsible for causing injury to another person or damage to another's property through negligence. And then negligence is the failure to use reasonable care, the failure to do something a reasonably prudent person would do in similar circumstances. And then peril is an insurance terminology for risk, possible cause of injury, or event causing damage or loss. Policy is a written contract for insurance between an insurance company and the insured party, right? Everyone has their own policy for their health insurance or for their car. A rider we've mentioned before, and that's a term to use to describe a document that amends or changes the original policy. An umbrella liability is a form of insurance protection in excess of the amount covered by other liability insurance policies. So this is umbrella liabilities are actually coming up more often as we see very high costs in pharmacy and medical spend. And then workers' compensation is a policy that pays benefits to an employee or his or her family for a job-related injury or death. I'm sure some of you have already dealt with workers' compensation claims at your pharmacy. So let's talk about the types of insurance for a pharmacy, specifically on slide 22. So we've got property insurance. This is one of the most common types of insurance for protecting the property and physical assets of a business entity. So these policies generally cover losses owing to a fire or theft or costs of removing property. Next is liability insurance, which can also be known as casualty insurance. So this protects a business entity against claims when it is sued for damages or injuries caused by negligence of the business or its employees. A business owner's policy, insurance companies commonly bundle property and liability coverage together in the same policy for small business owners. Pharmacists frequently purchase professional liability insurance, As I mentioned, I personally have the last 5 years had my own policy taken out on myself to ensure my practice of pharmacy is covered. Key person insurance. This is insurance designed to protect a business entity from financial loss if key individuals, very likely the owner or the partners, were to die or experience a disability. Umbrella or excess liability, we mentioned this before. It is possible that a lawsuit filed against a pharmacy could exceed the limits of its primary liability protection. So for example, let's say somehow your pharmacy is involved in a very serious issue where you are being sued for $1 million, but your insurance coverage is only for $500,000. So you could have an umbrella liability to help cover that second $500,000. Next is workers' compensation. Again, the statutory insurance covers medical expenses, disability income, and death benefits to dependents or an employee who may have an accident, illness, or death as job-related. So you would have a workman's compensation product for your employees if you are a pharmacy owner. And then also you'd offer disability insurance, which provides income to an employee and his or her family in the event that something happens, from preventing the employee from working outside of workman's comp. And then last, if you're an independent pharmacy insurance, you would actually work with a special company that provides insurance coverage to pharmacies specifically. And then last, I wanted to talk about the emerging risks associated with modern pharmacy practice. So everybody has probably heard of OBRA, the Omnibus Budget Reconciliation Act of 1990. So OBRA was enacted by Congress to establish the budget for all the nation's government agencies. So generally, OBRA has little to do specifically with pharmacy. But in 1990, the OBRA passed by Congress had implications for pharmaceutical costs and state Medicaid pharmacy programs. So in general, OBRA 90 specified what was expected of pharmacists in providing drug therapy to Medicaid patients. So that's, OBRA is where we first saw the mandate that pharmacists had to provide counseling to patients who were receiving Medicaid claims. And then HIPAA, the Health Insurance Portability and Accountability Act of 1996, set standards for the privacy of individuals' identifiable health information, and it went into effect in 2003. So Department of Health and Human Services, DHHS, was required by Congress to promulgate the privacy standards and to set security standards for patient health information. So for example, guys, if before 2003, you could technically, if you were in the elevator of a hospital, talk about patient information and say, patient XYZ had a myocardial infarction and we're going to administer heparin. And after 2003, you could not talk about that patient in an elevator where it was in a public space. So health information technology related risks. So the healthcare sector in general and pharmacies specifically have become increasingly dependent on information technology, right? We talked about that in our last lecture as far as electronic health records go and physician computerized order entry. Next is strategic risks. This is the first and foremost risk confronted by pharmacies implementing information technology. So to make any information technology project successful in the long run, pharmacies must assess the compatibility of the technology with their mission and goals. And then performance risk is the degree of uncertainty inherent in the procurement and application of information technology solutions that may keep the system from meeting its technical specifications or from being suitable for its intended use and consequences, right? We were talking about the implementation of Epic at a hospital and how frustrating that was. Actually, I can't remember if we were talking about that, but we were talking about Joel Osco putting in a new computer system, right? And how it was to enhance performance, but at the frustration of a lot of its employees. So wanting to make sure that when you're putting in information technology solutions that everybody is using them appropriately. And then operational risk is generally defined as the risk of loss resulting from inadequate or failed internal processes, people and systems, or external events. All right, guys, so that's chapter 9. And moving on to chapter 10, this is preventing and managing medication errors and what our role is in that. Medication errors are really a buzzword among healthcare practitioners in general. Traditionally, we've not had a great way of capturing medication errors, right? Because we can only discover them usually retrospectively, so that requires some sort of analysis. And up until recently, we're going to talk about this, we've really tried to delve into why errors are happening and how to prevent them. So really, patient safety became a major concern in 1999 with the release of the Institute of Medicine's To Err is Human. A lot of people were surprised that their report showed errors involving prescription medications killed up to 7,000 Americans a year. That is a very, very large number. And then they also, same entity, Institute of Medicine, reported in 2006 that preventing medications errors included or indicated that medication errors are among the most common medical errors, harming at least 1.5 million people everywhere or every year. And it happens everywhere, not just in community, but in hospital, pharmacy, long-term care, every practice. And with this increased attention to medication errors, concern has intensified in both the public and healthcare sectors. Research demonstrates that injuries resulting from medication errors generally are not the fault of individual healthcare professionals, but rather represent failures in a complex healthcare system. So medication error prevention starts with recognizing that errors are multifactorial and are faults of the system as a whole rather than results of the acts or omissions of the people in the system. Even when an error can be traced directly to a specific individual, the further investigation often determines that a number of factors such as poor order communication between the physician and pharmacist, dangerous storage practices in pharmacies, look-alike labeling may have played a role in the error. So protecting patients from inappropriate administration of medications has become an important focus for pharmacists and technicians, including those in ambulatory, acute care, long-term care, home care, and managed care settings. So I'll give you a great example. I mentioned my mom works in day surgery, and about 20 years ago, she was telling me how a nurse accidentally threw out a piece of tissue that was supposed to be reviewed by the pathologist to see if it was cancerous or not. And obviously this was a really big deal as the patient had undergone some type of minor surgery to remove this, but that it was really important to see if it was cancerous or not. And it actually turned out that there was not a good process for capturing the saved tissue sample. And so my mom actually spent a lot of time putting into place a better checklist to ensure that the tissue was provided to the pathology lab appropriately. And they had to have a talk, and at first there was a lot of emphasis to be placed on the nurse that accidentally threw away the tissue sample, but again, there was not a good checklist in place to ensure that the sample was properly contained. So it actually improved their processes overall. So the ISMP is the Institute of Safe Medication Practice. And if you guys haven't heard of them in all of your free time, right, which is very little, go to their website and check them out. They're a non-for-profit that actually talks about they're very open and very transparent about what type of medication errors they deal with, and they see what comes into them, and then they try to make recommendations on how you can improve upon them. One of my favorite ones, I don't know if it should be my favorite, is that there's actually quite a few reports of people using super glue instead of their gel cataract medicine. So actually applying, or the erythromycin gel for when you have an eye infection. So people accidentally taking the tiny metal tube of super glue and applying it along their eyelids, and then obviously you can imagine what happens after that. So there was not only one report, and I will tell you that report commonly comes up in ISMP's website. So They identified 10 key elements that have the greatest influence on medication use systems. These system-based causes of medication errors can be directly traced to weaknesses or failures in these key elements. So you can take a look at those, and by themselves, latent failures are often subtle and may not cause problems directly. So the potential consequences are often hidden, becoming apparent only when they occur in a certain sequence and combine with the active failures of an individual. Again, ISMP's background is that they will never place any blame on people reporting errors, and that the more people that report errors anonymously, the better it is for the healthcare system. Again, everyone thinks that they're probably the only person that is encountering this medication error, but if everybody was open and honest about reporting them, we would have much safer systems. And medication use is a complex process that consists of sub-processes such as ordering, preparing, dispensing, administration, and provision of patient education. So right, guys, everything we've talked about the last 2.5 lectures has been about how complicated our own profession is. And medication orders is at the heart of a lot of errors, and pharmacists have to be aware of the type of breakdowns that occur during the ordering process that can lead to errors. So let's talk about ordering medications on slide 27. So electronically generated prescriptions, either faxed or hand-delivered to pharmacy, right? So even a doctor's office that prints out an electronic piece of paper and hands it to the patient solves a lot of legibility issues, so much better than handwritten prescriptions. But they also introduce a number of other types of errors. So ISMP received reports in which prescribers included a second set of directions with a pre-programmed SIG. So let's look at the next slide, slide 28, where it talks about clonazepam. So it says 1 parentheses 1.0 milligrams end parentheses PO-QHS for 30 days. But then it says to take 0.5 milligrams every morning and 1.0 milligrams every night at bedtime, number 60. So this is incredibly confusing. So this prescription includes trailing zeros, right? We never put 1.0. It is always just 1. Anything with a 0.0 could lead someone to think it looks like 10 milligrams. They use error-prone abbreviations. So we always want to say, they say PO-QHS in the SIG, but then the special instructions include QAM and QHS. And so you can tell the SIG was pre-programmed to take 1 every night at bedtime, probably for sleep, but then this patient had special instructions. So just very, very confusing. Let's look at ordering medications on slide 29. So illegible handwriting, and again, I think I mentioned I'm a P14 guy, so I still got a lot of prescriptions that were handwritten back in the day, like 10 years ago, which is just crazy because who wants to take the time to write something out? But a lot of people still do it, and I'm sure if you work in a community pharmacy, you're still seeing a lot of those. So these are handwritten prescriptions are just still so risky. And even in a hospital setting, when an order is written in a hospital medical record, that can be very prone to errors. And then we also have lookalike drug names. So for example, if we look at the next slide on 30, this looks like, this is for Vantin 200 milligrams, which is an old drug, and it is misread for Vasotec 20 milligrams, which is enalapril. So just a very easy way to be confused. And now that we have electronic entry, the physician or the prescriber would be able to choose the Vantin from a drop-down menu and hopefully avoid this type of error. Let's also look at slide 31. This one is, I've seen this one a couple times. This is an order for Avandia for type 2 diabetes that was misread as Coumadin, a blood thinner, 4 milligrams, right? So there, it has the same strength, which is uncommon. And I don't think Avandia looks like Coumadin at all when it's printed, but when it's cursive like this, very, very confusing. And then on slide 32, we've got sound-alike names, right? So Verbal orders should be avoided at all costs. Anytime you can transmit a prescription electronically or by fax or even handwritten is still better than verbal, because it is a person-to-person and it relies on audiology, which is not as specific as being written down. Verbal orders should only be taken by authorized personnel, and if possible, a second person should listen while the prescription is being given, right? I mean, that's probably more common in a hospital, but that's not going to happen in community pharmacy. And then the order should be written down and then read back, repeating exactly what has been ordered, spelling the drug name for verification, and the strength using digit by digit technique for the dose. Physicians are encouraged to include complete directions, strengths, route of administration, and indication for use if appropriate. And then ISMP has actually delivered or has developed a list that contains several easily misinterpreted abbreviations. So guys, we actually don't like to use QD anymore for every day. People should actually write out the word daily, D-A-I-L-Y. That's what we prefer these days. And if we look at the next slide on 33, it looks like 60 regular insulin now, which is actually meant to say 6 units of Humalog insulin, right? So it was written down and misinterpreted. So these are also some ambiguous order examples and how you should avoid these specific rules if you're taking a prescription, right? So like I said, no leading zeros and don't use decimal points. If you're using a tablet strength, you want to be very specific on what the dose is. Is it milligrams? Is it milliliters? Is it micrograms? Specify liquid dosage forms by milliliters or preferably by milliliters. And that leads us to the apothecary system, right? So that's grains, grams, and ounces. So we actually don't want to use ounces. Like liquid dosage forms, 4 ounces, we really should be using 120 milliliters. That is more accurate. And then preparing and dispensing medications. So here are going to be the steps in filling a prescription in community pharmacy. And for most of you, this will be redundant, but I do want to just lay it out there in case anyone does not have any community pharmacy experience. So first, the prescriber sees the patient. They perform an assessment. They determine the appropriate medication, writes the order to communicate the order or verbally to the nursing personnel or to the pharmacy. These days, a verbal order is going to be much less common, mostly because of time, but also because of safety. Next, a direct copy of the order is transported by the patient or fax or e-prescription so that it reaches the pharmacy. The pharmacist or pharmacy technician reads the order and enters it into the pharmacy computer system. This is where a technician can do a little bit of quality assurance. Next, on slide 36, a pharmacist reviews the prescriber or pharmacy technician's computer entry and compares it with the original prescription, handwritten or electronic, performs a clinical screening, write a drug utilization review or DUR with respect to the need for the drug, allergies, other contradictions, is the dose right, and the proper route of administration. Next, a label or medication profile is printed. It's important that a copy of the original prescription or medication order continues to accompany the label or medication while it's being filled. Next, you want to choose an item for dispensing. A technician reviews both the label and the medication order for possible discrepancies. And then a pharmacist checks the technician's work, reviewing the label against the medication order and the dose that has been prepared. The drug is labeled and then dispensed. Last, the pharmacist is going to use the patient counseling session to further assess that the correct medication is being dispensed, right? We always want to say, what questions do you have for the pharmacist? We used to say, do you have any questions? But it's really best, and you'll learn about this in your motivational interviewing class and in your counseling labs, what questions do you have for the pharmacist? We really want to make sure that the patients understand their medication and its proper use. For refills and medications that the patient has received in the past, we still want to ask patients if they have any questions about the changes in the appearance of their product. And if patients or caregivers are provided with an administration device, such as an oral syringe or inhaler, pharmacists must ensure that the patient or caregiver understands how to use the device properly. In fact, one of my pharmacist friends just texted last night that she was trying to help a patient understand how to use a progesterone suppository vaginally to prevent the miscarriage of a fetus. So progesterone helps to strengthen the cervix, and there actually is not an applicator that goes along with the administration of the suppository. And so it was a female pharmacist and a female patient, but there was still some misunderstanding of how exactly to use the medication as a vaginal suppository. And she was just commenting on how difficult it was even as a woman to try to relay that. Last, wrapping up, patients in the community setting should be educated about the common adverse effects of medications they are taking and understand what clinical signs to watch for. Right, guys, again, in Chicago and in the state of Illinois, it now is mandate that you have to cover, I believe it's 10 points when counseling. So again, this is always something that should be done, but it was actually put into law. And then the final step is adherence to medication therapy. Right, and we've talked a lot about adherence and ways to measure that. So even though you dispense a prescription, technically you should still be monitoring a patient and probably get alerts at your pharmacy, especially CVS. They will measure and make outreach calls if someone does not fill their prescription on time. All right, let's talk about filling prescriptions at a hospital pharmacy. This may be a little bit newer to some people who have not worked or had an IPI in a hospital yet. So prescriber sees the patient here. Again, it's going to be an inpatient setting. They're going to have an assessment on the patient's condition, what's the appropriate medication. So far, exactly the same as community pharmacy. And they're going to write or communicate the order verbally or electronically. If an organization uses handwritten communications, right? So we still have unit secretaries that read and transcribe the order onto the medication administration record, or the MAR. A nurse checks the unit secretary's transcription for accuracy. This step is unnecessary in hospitals where computers generate an electronic medical record, right? We talked about, again, physician order entry, computerized physician order entry, CPOE, or the pharmacy prints the MARs for the nursing staff. Next, a direct copy of the order is transported, faxed, scanned to the pharmacy, or the prescriber's computer entry system reaches the pharmacy's order entry system. The pharmacist or pharmacy technician reads the order and enters it into the pharmacy computer system. Next, a pharmacist reviews the prescriber or pharmacy technician's computer entry, compares it with the original prescription, performs a clinical screening of the prescription in respect to the need for the drug, allergies, other contradictions, proper dose, and proper route of administration. Right, guys? Very similar to community pharmacy. Next, a pharmacy label is printed. A copy of the medication order continues to accompany the label while the order is being filled. Orders should never be filled solely on the basis of what appears on the label, because the computer entry may have been an error. So to choose an item for dispensing, a technician reviews both the label and the medication order for possible discrepancies. So we never want to pull a drug just based on the label, right? Although we do that a lot in the practice of pharmacy, technically we should have the prescription order with it to make sure that we're not wasting time filling off of a mistyped label. Next, a pharmacist checks the technician's work, we're on slide 40, and reviews the label against the medication order and the dose that has been prepared. The drug is labeled and dispensed. The medications are delivered to the patient care area. Medications are stored in a variety of areas that include patient cassettes, bins, or automated dispensing cabinets, or ADCs. We'll talk about those a little bit later. The nurse obtains the drug and compares the medication and pharmacy label against the copy of the physician's order, as well as the medication administration record, or the EMAR. The nurse administers the dose, given the drug's name, explains the drug's purpose and potential adverse effects, and answers any questions and concerns raised by the patient. Right, guys, in these days, you'll probably see when a nurse administers a medication in the patient's room, they scan the barcode of the patient, they scan the barcode of the drug, and then maybe even scan the barcode of the patient, again, if it's an infused medication or a high-risk drug. Next, when we're selecting medications to be filled on slide 41, this is very interesting in general for community and hospital pharmacy. So a lot of times the wrong drug strength or concentration is dispensed, and a lot of these errors stem from failure to read the label thoroughly. And this is just because we're human. Our eyes or brain misinterpret what they're seeing. And during drug preparation and dispensing, the label should be read 3 times. And that's when the product is selected on order entry, when the medication is prepared, or when you're filling the prescription, and either when either the partially used medication is disposed of or product preparation is complete. So that's in community pharmacy, you're looking at the bottle and you put it back with the other bottles. And then, or in hospital, if you're putting it back into an automated dispensing cabinet. So you guys have probably seen these if you've had an IPI in a hospital setting. They're computerized drug storage devices or cabinets that allow medications to be stored or dispensed near the point of care while controlling and tracking drug distribution. So of course, with any technology that can be prone to errors, the pharmacy can replenish the system with an incorrect medication. The nurse can retrieve either the wrong item or additional items to use for other patients, right? So let's say you're opening, for example, just for visual sake, you're opening a fishing tackle box and it says to use the box number 1. If for some reason you reach into box number 2, again, just because of a miscommunication in your brain, that can be prone to error. So, for example, a lot of ADCs, these cabinets are going to have controlled substances where only one part is going to open at a time instead of a whole tray that opens up where you may have access to multiple medications. And for ADCs without profiling capabilities, most hospital systems, again, right, so if your entire tackle box opens up and you're able to access all of the openings, you really want to make sure you have a pharmacist double checking and screening orders before a nurse withdraws a medication from the cabinet. A lot of prescribing errors, wrong dosages, incorrect routes of administration, and clinical errors have occurred with these cabinets. So let's look at slide 42. To me, I always think this is not that big a deal because I know what enalaprate is and what pancurium is for, so how could I ever mix those up? But for a pharmacist or a technician who's not as familiar with this medication, these technically, the labels look exactly the same. This is a black and white picture, so it's hard to see if the color is the same, but the text and the font and the size of the lettering is exactly the same. And the dose is also very similar as well, right? 2 mg per ml. And so similar packaging might lead to medication errors. ISMP, again, has done a lot of studies on how this is very inappropriate manufacturing practices. You should have your medications look completely different. We also find a lot of errors with sterile admixture preparation. So when you're preparing fluids for injection administration, the potential for grave errors is increased for several reasons, right? These patients are usually sicker. If they need intravenous drugs, the medications have a more dramatic effect on the body's function and physiology. Last, most injectable solutions are clear, colorless, and water-based fluids that all look alike. So it's not like you can look at a drug and say, oh, this has an M16 on it, and this has a C34 on it. Okay, these are 2 different medications. So in sterile admixture preparation setting, dosage miscalculations and measurement errors must be minimized by systems designed with procedures that require independent double checks by 2 staff members. So usually if a technician is preparing sterile admixture preparations in the hood, they will lay out exactly how many mils they used in a syringe, and they will have the pharmacist double check those calculations. And in many pharmacies, independent double checks are required for all calculations and measurements, and others may require it only for calculations falling into special categories, such as doses calculations for admixture compounding for any child under 12, critical care drug infusions requiring a dose in micrograms per kilogram per minute, right? A very, very small dose, insulin infusions, chemotherapy, and patient-controlled analgesia or pain control. So let's talk about patient counseling and education on slide 45. And we won't go into too much detail because this will be a big part of your pharmacy education and your practice. Really contributing to this gap in patient education is a failure to provide patients with understandable written instructions. So one reason for this lack of understanding may be that people who have difficulty reading or understanding health information are too embarrassed or ashamed to acknowledge their deficits. And instead, they're hesitant to ask questions of their healthcare professionals and often pretend to understand instructions. And their health literacy is low, but it may not be obvious. Researchers actually have reported that poor reading skills are common in some of the most poised and articulate patients. And then compliance is also a related patient factor contributing to medication errors. So one study found that a 76% difference occurred between medications patients are actually taking when compared to those recorded in their charts as prescribed, right? So a big idea that we're trying to advocate is medication reconciliation, and that's to address this issue. So it's essentially verifying that the medications a patient says they're taking are what they're supposed to be taking. And two factors that contribute to this high rate and discrepancy include confusion that may accompany advancing age and the increase in the number of prescribed medications, right guys? So if we have older patients and let's say they're on 16 medications, it's really hard for them to remember what they're on and what they're supposed to be taking their medications for. So basically, we do have a new model of accountability, right guys? Legally in the state of Illinois, I've mentioned this a few times now, it really is important that pharmacists counsel their patients and have to hit on a certain number of checklist items, like what the medication is for, the most common side effects, what adverse reactions to expect. So in our model, our new model of accountability to continue, even though we know that there are a lot of system-based causes of errors, a lot of people in healthcare are still struggling to come to terms with the role of individual accountability. Even when we seem to understand that the system-based is causes of errors, it's still hard to let individuals off the hook. So we ask, how can we hold individuals accountable for their actions without punishments? So some have suggested that a non-punitive approach to error reduction leads to increased carelessness as people learn that they will not be punished. But that is actually contradictory to the outcomes that we have. So we've actually found that, I don't know if you guys know the whack-a-mole game that is at carnivals, right? So this requires bopping a mole that sticks its head out of a frame and trying to bonk it back down. So that's actually how a lot of people discuss medication errors, is that we try to hurt the people that report the errors or come clean about them, and we try to punish the person. And all that does is drive people underground and not want to report the errors because of risk of being punished. So a lot of companies and healthcare systems are trying to have a non-punitive process, but also just to make sure that they're improving their processes. And this will be something that'll come up when you're practicing, and you want to be sure to ask your employer, how do we report medication errors? Where can I learn about medication errors? What's my responsibility for reporting medication errors? And am I going to be supported if I do make an error that's related to a system process? These are all really good questions to ask your employer before you start a job. And then we are trying to create better, effective risk reduction strategies. So it's really hard to choose the best error prevention strategy. Usually the most effective action is not obvious, right? If we could build a computer system that ensured no pharmacy errors, maybe one day that will happen, but obviously we don't have that yet. Pharmacists really should focus their efforts on medications that may lead to harm if involved with an error. So although most medications have a wide margin of safety, there are a few drugs that have a high risk of causing patient injury or death, right? So we really want to focus on these high alert medications. I think we mentioned this before, but Coumadin and insulin are the two drugs that are most commonly associated with medication errors. And they're so straightforward and pretty easy to use and so prevalent to use, but because of their high alert risks, there are so many issues and medications errors related to these. And then lastly, we have our risk identification methods. So all medication dispensing procedures should be examined regularly, both proactively and retrospectively, and the potential problems as well as causes of system breakdowns must be discovered so that prevention measures can be designed. Pharmacy staff needs to communicate clearly to managers what is their job and what takes to do the job correctly in terms of personnel, training programs, facilities design, equipment, drug procedures and supplies, computer systems, and quality assurance programs. In addition, reducing medication errors usually involves a number of effective risk identification methods, including non-punitive environment and a voluntary medication error reporting system that can be anonymous. So let's conclude on error prevention, as probably everyone is pretty worried now about making errors. Everybody is going to make an error, right? That is just statistically significant. What is not significant is the clinical significance of those errors, guys. Of course, you are human, but if you're following the processes put in place and you have you're spending the time and the resources on correctly filling the medication, then that is going to drastically reduce medication errors. Moving quickly or saying you don't have enough staff is not going to be an excuse if you make a medication error. You have to take your time and make sure that you're putting in the proper effort and following the guidelines. And that's something that we have to do together as a profession. So we really play a key role in the drug use processes throughout any healthcare organization, right? So we should be the ones talking about medication errors because we're the medication specialists. Administrators in both hospitals and community pharmacy should encourage their staff to collaborate on quality assurance programs, right? QCI is an ongoing process, like we talked about in the last chapter, that should never stop trying to be improved upon as how to reduce medication errors. And then quality assurance efforts that review a medication error report helps to better understand the type of systemic and behavioral defects being experienced so that necessary corrections can be identified. This is going to be a team effort by you and your staff, all the pharmacies in your business, or the hospital system that you're in. It really is going to be a team effort to help provide better medication safety for our patients. All right, guys, let's wrap up with Chapter 11, Compliance with Regulations and Regulatory Bodies. Again, this is going to be a little bit more technical, but an important issue that we want to talk about. So let's talk about standards for pharmacist professional performance, right, and where these came from. Before there were laws like the Pharmacy Practice Act of every state, right? Illinois has a Pharmacy Practice Act that I have to adhere to because I'm licensed in the state of Illinois. There were standards and codes of ethics established by professional guilds and associations. And these were codes of ethics stated in a formal way with the type and level of professional performance that a guild or association expected from its members. So why do we have laws governing drugs and our profession? During this time, from colonial times, right, to modern times, and we talked about this on our first day when we had introduction to pharmacy practice, pharmacy made the transition from an unlicensed occupation that in many ways resembled a trade, right, you had to go through an apprenticeship, to its current status requiring a professional doctorate, your PharmD degree, to become eligible for licensure. And professionals are expected and were expected to be ethical and honest in their dealings with the public. And the pharmacy profession was largely self-regulating, and with the sanctions from within its ranks as the only punishment for a violation of the profession standards. So now, for example, you would have to adhere to what APHA, American Pharmacists Association, said was to be your practice. So we're going to talk about the historical overview of legal developments and then also what federal law says about our conduct. So guys, just real quick, there were a couple of historical instances that we talked about again in our first day of lecture, right? The Food, Drug, and Cosmetic Act of 1938, so that required drugs to be pure and labeled accurately and contained no requirement for drugs to be safe. So that's when manufacturing really took over, and we wanted to make sure that drugs that were manufactured followed strict guidelines and were safe for consumption. And then the establishment of state pharmacy practice acts and state boards of pharmacy, right? So I mentioned that each state has their own pharmacy practice act, but they also have boards of pharmacy that govern how the practice act should be created and monitored. So we have an Illinois Board of Pharmacy. It meets every other month, and actually, I take that back. I think it meets 8 times a year, and it does not create laws to put into the Pharmacy Practice Act, but it is rather a monitoring and recommendation body. So they take what's going on in the marketplace in the practice of pharmacy and what other states are doing, and they make recommendations on how to update the Practice of Pharmacy Act in each state. So you can actually attend these meetings. They are open. If anyone's ever interested or available and wants to come with me, please let me know. So let's talk about federal law and how that affects the conduct of pharmacists, right? So we talked about the OBRA Act of 1990. So this had 3 limitations that it put into place, rather recommendations. Maintaining proper patient records, right? So pharmacies must make reasonable efforts to obtain, record, and maintain at least the following patient information: patient name, address, telephone, age, gender, individual history where significant, including disease states or state, known allergies or drug reaction, a comprehensive list of medications and relevant devices, and pharmacist comments about the patient's drug therapy. So this is where we get a new patient to the pharmacy. We want to add them to the system. We have to make sure we have a comprehensive medical and history on them. And then we have a prospective use, or PRO-DUR. So prior to dispensing a prescription, a pharmacist must conduct an evaluation of a patient's medication record to detect potential therapy problems such as therapeutic duplication, drug disease, contraindications, drug-drug reactions, incorrect dose or duration of a drug treatment, drug allergy interactions, and evidence of clinical abuse or misuse. Patient counseling. A dispensing pharmacist must offer to counsel regarding matters that are, in the pharmacist's professional judgment, significant, which include, but are not limited to, name, description of the medication, route of administration, the dose, the dosage form, and duration of therapy. In addition, such standards require pharmacists to discuss special precautions and directions, common severe side effects or interactions, therapeutic contraindications that may be encountered, proper storage techniques for self-monitoring or drug therapy, and what to do if a dose is missed, and refill information. And guys, I included a link to the Illinois Department of Professional Regulation that talks about the new pharmacy patient counseling rules that took effect on August 18th of 2017. So you might want to take a look at that because it does outline exactly what OBRA, it extrapolates out OBRA to our state. And then for HIPAA, and we talked about HIPAA in the previous chapter, for you guys, as a pharmacy manager, you really need to know the answers to the following questions, right? So who's covered by the privacy rule of the employer? What information is protected? And what must a covered entity like a pharmacy do to protect information? So we have to make sure all our employees of a pharmacy are trained in HIPAA rules and procedures as a condition of employment. I know I have to complete an annual HIPAA update to be an employee of CVS. Under the HIPAA privacy rule, all covered entities are required to provide patients with a notice of privacy practices. I think we can deliver those electronically now, but I know every time I go to a physician or a new pharmacy, I get a copy of HIPAA. We also have to talk about our business associates, right? So that's a person or an organization other than a member of the covered entity's workforce that performs certain functions or activities on behalf of or provides certain services to a covered entity that involve the use or disclosure of individual identifiable health information. So business associate functions or activities on behalf of a covered entity, including claims processing, data analysis, utilization review, and billing. So for example, guys, I've mentioned that in my clinical advisor role for CVS, I work with a consulting group. We have a non-disclosure agreement with them, or an NDA. So that means we do not share any patient information with them. They are not allowed to have access to HIPAA, but they are covered and so that they can review data analysis and utilization review of our mutual employer clients so that they can make recommendations. All right, let's wrap up how the federal law and the conduct of the pharmacist is affected by different mandates. So next is the Prescription Drug Marketing Act. So pharmacy managers must also comply with federal laws regulating the economic issues in pharmacy. So the Prescription Drug Marketing Act of 1987 represents one area where pharmacists have encountered considerable legal problems, resulting in large fines and/or prison sentences. So just quickly, the PDMA prohibits the diversion of prescription drug samples into the retail market sector. Pharmacies may not have in their stock any prescription drug samples, and pharmacies may not possess or sell any prescription drug samples. Next is the State Prescription Drug Monitoring Program, and I attached a link to the Illinois Patient Monitoring Program. This was set up to curb the practice of doctor shopping that is used by some patients to obtain controlled substances. A number of states have enacted a Prescription Drug Monitoring Program, PDMP. These PDMPs collect information on controlled substances and drugs of concern dispensed within the state and maintain an electronic database of that information. And actually, there were, up until just this past year, all 49 states had a PMP except for Missouri. And ironically, Missouri has one of the highest rates of illicit drug use. So they finally just got on board. And the reason they did it was a lack of funding to enact a PMP. And last, civil law and liability concerns. So guys, again, there is a lot of risk inherent in what we do in healthcare and especially in pharmacy. So, you know, the thought of being sued, doing something that you love and while you're practicing and you're doing everything that I can do is really scary, and there is just inherent risk, and that's what we talked about in our previous chapter. And when a pharmacist or pharmacy organization is sued, the issue of negligence becomes the key to what the outcome of the lawsuit will be. Negligence theory revolves around the failure to do something that a reasonable and prudent person would do, or doing something that a reasonable and prudent person would not do. And in that case, the person is the pharmacist, right? So that's why it's a PharmD. You are entrusted with knowledge and information on how to practice appropriately. And if you are going to be found negligent, it is probably because you are actively disregarding your pharmacy knowledge. And just for a disclaimer, I do not know anything about the law, and this is not legal recommendations. All right, guys, and we're on slide 53. Again, we do want to just talk about how legal standards affect our practice, right? So it is important, if you are the pharmacy manager, and even if you are a staff pharmacist, to understand the statutory and regulatory standards, right, of state, federal, and local laws that create an environment context for an organization. And that is really critical on determining whether or not your organization or your employer prospers and grows if they are adherent to all of the regulations. This chapter really wanted to emphasize that avoiding legal sanctions for practitioners or pharmacy, the manager takes steps to prevent and actively avoid substandard practices that could lead to penalties, right? So the last point is everybody wants to make sure that they're adhering to OBRA and to other practice acts and the Pharmacy Practice Acts and HIPAA, and that should be a bare minimum. But really, your pharmacy should be practicing at a higher level, right? So if you are establishing standards of performance that exceed the legal minimum, it is much less likely that performance quality will result in violations of the law. So if your pharmacy is practicing at a very high level, chances are that something nefarious is going to happen, or that you are going to be charged with negligence is going to be extremely low. For example, a state's Pharmacy Practice Act creates a board that I mentioned and empowers that board to establish rules and regulations to interpret or implement the Practice Act. Though the Board of Pharmacy Regulations carry the full force of the law and establish penalties anywhere from warnings, fines, and suspension or revocation of a pharmacist or pharmacy's licensure. And that's why I invite you guys, if anyone ever wants to go with or wants to discuss what happens on the board of pharmacy, that's really important because they are going to make sure that every pharmacist is practicing appropriately and ensuring that there are high levels to our practice. All right, guys, let's bring it home with slide 54 in your assignment that is due by the beginning of the next class. And this is worth 5 points. So I put a link to a New York Times article that is in regards to a pharmacist. I would like you to read the article and then reflect on 2 questions. And I would, like I said, this assignment is worth 5 points. I need you to type out your answers to the 2 questions. If you can, copy and paste question 1 and then copy and paste question 2 and put your answers below. There is no minimum or maximum amount of sentences needed to complete this assignment. Please put your full name at the top of the paper so I know who you are and I can record that you turned in the assignment. And it will be due prior to starting class at 10 a.m. next week on March 20th. It is a pretty fascinating article, so we can talk a little bit about it once we get to class if we have time. All right, that concludes the lecture for week 3. I hope you enjoyed this presentation and I look forward to seeing you guys next week. Have a great week this week. Bye.